Hello, everybody. Please take your seats. We are ready to get started. I would welcome you to our late-breaking clinical trial session, the second one in the series. And I'm Dr. Matthias Kratzler. I'm a nephrologist and computational biologist at the University of Michigan.
Hi, everyone. My name is Nisha Bansal. I'm a professor at the University of Washington.
And we will start our session with the same procedure as yesterday. So please see at the barcode you have coming up, load it into your cell phone. This will allow you to ask questions via your cell phone, which we then will pose towards the presenter as we transition into the discussion stage of the presentation. But also keep your cell phones quiet so that we don't interrupt our session. The session will be recorded and made available in the ASN e-learning center in late November. Please also see the disclosure of our presenters as we move forward. And with this, we would like to start with our first presentation, Impact of Targeted Hyponatremia Corrections on 30-Day Mortality and Rehospitalization Rates, presented by Julie Raffert from the University Hospital in Basel, Switzerland, and the Erasmus Medical Center in Rotterdam. After the presentation from Dr. Raffert, Dr. Pollock will be a discussion, so there will be no opportunity to have questions from you directly answered, but both presenter and discussions will be available at the end of the session at 12:30. Dr. Raffert, please.
Dear colleagues, thank you so much for giving me the opportunity to present the results of our study, Impact of Targeted Hyponatremia Correction on 30-day mortality and rehospitalization rate. I have nothing to disclose. However, I would like to stress that this study would not have been possible without the support of the investigator-initiated clinical trial grant by the Swiss National Science Foundation. Now, as you know, chronic hyponatremia can have many causes. It can be due to free water excess, such as in the syndrome of inappropriate antidiuresis, SIAD. It can be due to volume deficit, as in patients with gastrointestinal loss, blood loss, or cortisol deficiency, or it can be due to volume overload due to heart failure, liver failure, or kidney failure. However, we also know that these causes often overlap, making the diagnosis and treatment of hyponatremia very challenging. Accordingly, it came as no big surprise to many of us when the data of the hyponatremia registry outcome were published, showing that in hospitalized patients, up to 25% of patients with mild to moderate hyponatremia did not get any treatment, and the majority of patients were discharged with still being hyponatremic. However, what is the data that we should treat hyponatremia? Now, we know from several clinical trials that chronic hyponatremia is associated with neurocognitive disorders, gait instability and falls, osteoporosis, and also adverse outcomes such as an increased rate of rehospitalization, adverse outcome, and death. However, data that treatment of hyponatremia really improves these disorders is not very strong or sometimes even absent. So we do know from secondary analysis from prospective trials that neurocognitive disorders and gait instability seems to improve when we treat our patients. And we also know that bone resorption markers change when we treat hyponatremia. However, whether the rehospitalization rate and mortality rate improves if we treat the patients, that we do not know. Accordingly, the main questions we still have not answered until now is the adverse outcome and chronic hyponatremia, is that causation or correlation? Accordingly, we decided to tackle this question. So we designed the largest prospective randomized hyponatremia interventional trial so far. And we included patients hospitalized, having a hypertonic hyponatremia below 130 millimoles per liter. Patients were then randomized in two groups. In one group, they received targeted correction of hyponatremia. That means that our study teams daily looked at the hyponatremia and the treatment and changed it or adjusted it with the aim to reach normonatremia. In the other group, patients received standard treatment of hyponatremia, so it was in the responsibility of the attending physician, and we do know that that is sometimes no treatment, but sometimes also good treatment, so that was just the standard treatment. Our intervention lasted as long as the patients were hospitalized. Once they were discharged, there was no further intervention from our study team. And it's important to note that we did not have any influence at the time point when patients were discharged. The primary endpoint of our study was the 30-day mortality and rehospitalization rate. So we aimed to have a pragmatic trial, so we only had few exclusion criteria. So as I said, we included adult hospitalized patients with chronic hypertonic hyponatremia below 130 millimole per liter. We did not include severely symptomatic hyponatremia in need of hypertonic saline. That was because of safety reasons, because we did not want to delay treatment while including these patients. We also did not include patients with end-of-life care, end-stage kidney disease, acute liver failure, encephalopathy, or hepatorenal syndrome. We had 9 amazing recruitment centers throughout Europe, 5 in Switzerland, 1 in the Netherlands, 1 in Croatia, 1 in Italy, and 1 in Germany. And it took us nearly 6 years to conclude the study. During these 6 years, we were able to recruit 2,174 patients. In blue, you can see the patients in the control group, which were 1,095. In purple, the intervention patients, which were 1,079. And as you can see in this table, just how nicely randomization works, because baseline serum sodium level were not different between the groups, with a median of 127 millimoles per liter. As we also know from other data, was also shown in other studies, that the main cause of hyponatremia in our patients was euvolemic hyponatremia with around 52 to 55%. Second main cause was hypovolemic hyponatremia, and the third main cause, hypervolemic hyponatremia. SIED was the main cause of euvolemic hyponatremia, which was also similar between the two groups. There were slightly more female patients in our study, and the median age was 72 years. Now, how did our intervention work? Here in this Kaplan-Meier graph, you see the rate of patients reaching normonatremia. In purple, the intervention group, in blue, the control group. And you can see that through our intervention, 60.4% of the patients reached normonatremia during hospitalization, compared to 46.2% in the control group. However, when we looked at the primary outcome, the 30-day combined mortality and rehospitalization rate, we saw that there was no difference between the two groups, with patients having a rate of 21% in the intervention group and 22.2% in the control group, leading to a difference of 1.2%, which was not significant. How about if we look at death rate and rehospitalization rate differently? So again, in purple, the intervention group, in blue, the control group, but also here we did not see a difference between the two groups, with having a mortality rate of 8.6% in the intervention group and 8.5% in the control group, and a rehospitalization rate of 13% in the intervention group and 14% in the control group. The majority of our patients reached a serum sodium level below 130 millimole per liter, and there were more patients discharged normonatremic in the intervention group than in the control group. However, you can see at the 30-day follow-up, around 41 to 42% of the patients were again hyponatremic. Now, you could maybe say, well, 60% of patients reaching normonatremia, we are a bit disappointed about that. Why didn't you do better? And we were also a bit disappointed in the beginning, but it seems to be that some patients with hyponatremia you cannot normalize with the guideline treatment we have at the moment because they're just too ill. But we wanted to see if maybe the normalization rate had an impact on the event rate. And this I would like to show you in this a bit complicated graph. So on the y-axis, you see the event rate. On the x-axis, you see the normonatremia rate treatment. Again, in purple, the intervention, in blue, the control group. And you can see it didn't matter about the quote of the normonatremia rate. It had no impact on the event rate. However, as was also described in other studies, we did see that if a patient was discharged with normonatremia, this was associated with a 25% lower odds of having the primary outcome. But this was independent of the treatment. Now, what about the subgroup analysis? Is there maybe a group that would profit from a targeted intervention of the hyponatremia? So we looked at different subgroups. We looked at the severity of hyponatremia. We looked at etiology of hyponatremia, hypovolemic versus euvolemic, hypervolemic versus euvolemic. We looked at hyponatremia treatment, fluid restriction, urea, vaptans, and also sex and age difference. But to make a long story short, there was no difference between the two groups. Now, what about safety of the intervention? We had very low numbers of sodium overcorrection in both groups, with 2.4% in the intervention group and 1.5% in the control group. And there were even less adverse events due to the sodium overcorrection. That means patients were sometimes hospitalized for a longer time if that happened, which was 1.2% in the intervention group and 0.8% in the control group. There were also very few episodes of severely symptomatic hyponatremia during the intervention, with 5 patients in the intervention group and 1 in the control group. Now, there are some limitations to our study. First, I think it's important to stress that these results apply to hospitalized patients. So we do not know if targeted treatment of hyponatremia would have an effect on the mortality and rehospitalization rate in outpatients. Also, I think it's important to know that our patients mostly had mild to moderate hyponatremia, only few had severe hyponatremia, and we cannot say that we should not treat hyponatremia because our comparison was the standard of care, not no treatment. And with this, I would like to conclude. So in this largest prospective randomized hyponatremia intervention trial, we saw that targeted plasma sodium correction did not reduce 30-day mortality and rehospitalization rate. This result was robust in the per-protocol analysis and in the subgroup analysis. Accordingly, I believe that in hospitalized patients, chronic hyponatremia seems to be a marker of disease severity rather than a cause of worse outcome. Now, this study would not have been possible without the support of our amazing study centers in Cologne, Germany, in Florence, Italy, in Rotterdam, the Netherlands, in Zagreb, Croatia, and in our 5 amazing Swiss centers. And here on the picture, you see the inner circle of our hyponatremia intervention team. And in the blue circle, you see the heart and the brain of our study team, Professor Miriam Chris Crane. And again, I would like to thank everyone and also the Swiss National Science Foundation for the support. Thank you very much.
Thank you so much for an excellent presentation. Next up, we're going to have Dr. Carol Pollack from the University of Sydney serve as a discussant for this presentation.
not coming up. Oh, there we are. So first of all, I'd like to congratulate Dr. Refart for conducting this study. I think most studies that have been done in the past have been retrospective studies, and they always finish with a conclusion saying what we need is a prospective study looking at treatment of hyponatremia. So there were some of my own limitations. I could access the slides, but I wasn't aware of what Dr. Refart was going to present. And so I realised that these are only some of the results, and I look forward to the full paper. So I think that this was the slide that looked at the study protocol, and I did have a couple of questions. Firstly, was how was chronic hyponatremia determined rather than acute hyponatremia? Because I think that should modify the treatment. Also, I wondered what standard of care was because there are several different protocols that would change with different forms of hyponatremia. And I wondered what the treatment algorithm was, whether that was all standardised by the study team. So these are the patient characteristics, and as was pointed out, it was a fairly mild to moderate hyponatremia in the study. When we look at the causes of hyponatremia, it only really adds up to about 80%. So I wondered what the other causes of hyponatremia were. And I think it's also important to look at the other electrolytes, particularly potassium and phosphate, as potassium and phosphate have been shown to be low in people that are at risk of rapid correction, for instance. I was also interested in the numbers of people who may be malnourished or have alcoholism, because again, that predictates how rapidly the sodium should be corrected. So to summarise, this large intervention trial with targeted plasma sodium correction did not reduce the 30-day mortality and hospitalisation rates, but as was pointed out, if normonatremia was achieved at discharge, there was a lower odds of rehospitalisation or death. Having said that, the people that were discharged, a large percentage of them still had residual hyponatremia. I think that the result was robust in the per protocol analysis and in the subgroup analysis. And I think that we can say that hyponatremia was a marker of disease severity. And in particular, there was the prognosis with the patients with the syndrome of antidiuresis was better than the outcome of people with cancer. The safety profile of both strategies was similar, but I was interested as to the safety profile, particularly in the people who had severe hyponatremia, which was a small number, but also I wasn't clear what was how was severe hyponatremia actually defined. And I think, protocolized treatment did appear to be favourable in this study, as is in general protocolized treatment. More patients are likely to receive a better outcome. So if we put this in context, I think the historical focus on hyponatremia has really focused on retrospective studies, and the retrospective studies have largely looked at osmotic demyelination syndrome due to either the hyponatremia or due to the rate of correction of hyponatremia. And in this study, we don't know what the rate of correction of hyponatremia was. I think that mostly the retrospective studies have been because there is physician anxiety about the rare risk of calamitous iatrogenic disease with over correction or with too rapid correction. But I think that there is still concern in the literature about what actually does cause osmotic demyelination syndrome. Is it a result of the underlying disease? Is it the rate of correction? Is it the degree of hyponatremia at the beginning? So there have been consensus recommendations with minor variations about how to treat hyponatremia, and as I say, I'm unclear how this was treated in this particular study. And the treatments do differ according to the degree of hyponatremia and the rate of development of the hyponatremia. And again, in this study, it was suggested that it was all chronic, but I'm not sure how that was determined. I think also there have been some recent studies that have allayed the risk of rapid correction of hyponatremia, but that is balanced with some more conservative views from clinicians who are perhaps looking at patients with a more severe degree of hyponatremia, with serum sodiums far lower than was demonstrated in this study. And I've just put up some of these recent publications. I think this top publication on up here was just published earlier this month online a couple of months ago, and this looks at treatments in largely in the European population. This down here by Macmillan really was the disruptor in the treatment of hyponatremia. They had a similar level of hyponatremia as was observed in this study. They looked at about 17,000 unique patients, 22,000 episodes of hyponatremia, and they looked at the rate of correction and then looked at complications. And what they found was that the rate of correction had no relationship to the rate of or the incidence of osmotic demyelination syndrome. In fact, there was only 12 episodes of osmotic demyelination in that large number of patients in this retrospective study, and in fact 58% of the people who had osmotic demyelination were people in the slower rate of correction. If we look at this study here, this was again published last year, and they looked at the rate of correction being less than 6 millimoles in 24 hours or more than 10 millimoles in 24 hours. They again looked at mortality and rehospitalisation, and there were actually fewer in the people who were corrected at a faster rate versus a lower rate. This has also been borne out in an ICU population. This was about 1,000 odd patients, and they demonstrated a cost effectiveness of a rapid correction of serum sodium with fewer ICU days and a faster hospital discharge. But this paper here from earlier this year in C. Jason actually put a tempering note on the rate of correction, and I think Julie was one of the authors of this paper that suggested that hyponatremia shouldn't be corrected too rapidly. The first author being Richard Stearns, and I think he has been concerned about the rate of correction of hyponatremia for many years. So if we look then at how what I will do now based on the results of this study, I think I'll feel more comfortable about attempts to improve hyponatremia more rapidly with the aim of early discharge, which I think is a cost-effective benefit as demonstrated by a 25% lower risk of rehospitalisation. But how that's done isn't clear, and it does depend on the cause. And the options include these, and the only other thing that I would add to the talk is that SGLT2 inhibitors have been shown to improve hyponatremia compared to placebo. But I look forward to the paper, and no doubt more informative detail will come through in the publication. Thank you.
Thank you so much, both to Dr. Reffard and Dr. Pollack, who both will be available after the session to answer additional questions.
And we would like to ask Dr. Carla Nestor from the University of Iowa to present now the VALENT study, a randomized, multicenter, double-blind, placebo-controlled phase 3 trial of pegcetacoplan for patients with native or post-transplant recurrent glomerulonephritis or primary immune complex membranoproliferative glomitis. Dr. Nestor, please.
Thank you to the organizers, and particularly I want to say thank you to the patients, and actually I'm presenting this on behalf of a lot of different investigators, so of course I want to thank them, and then of course I'll thank the sponsor. Here are the disclosures for each of the investigators. I want to very quickly share with you what the mechanism is, and this is a targeted C3, C3b inhibitor, and it acts centrally in the alternative pathway to block both the alternative pathway and downstream in that pathway, such that you get C3 blockade, C3b blockade, and by virtue of doing that, you actually even block the C3 convertase and also the C5 convertase. That in turn will end up blocking a good deal of renal inflammation, and then finally it will actually inhibit the direct structural renal damage that actually happens from the membrane attack complex by virtue of C5 convertase activity. VALIANT is a double-blind, randomized, placebo-controlled phase 3 study. Patients were randomized 1-to-1 after a screening period, at which time it was just being made clear that they were on maximally treated ACE inhibition, ARB, etc. This is fairly standard in our clinical trials these days. These patients were also allowed to be on whatever expert-guided care that they were on, meaning if they were on mycophenolate, they stayed on mycophenolate, needed to be stable for 90 days. If they were on steroids, they stayed on steroids. It needed to be at a slightly lower dose. You'll see that in just a few moments. But they were randomized 1-to-1 once they were stable at least 90 days on their dosing. They were given either 1,080 milligrams of subcutaneous infusion of pegcetacoplan, and I apologize, I'm going to try to pronounce this correct all the way through, versus placebo. These patients were followed for 26 weeks before we collected the primary endpoint, and in fact, that's what you're seeing today is the primary endpoints that were taken from this placebo-controlled trial. Here are our eligibility criteria. There's a number of very significant things here. First of all, this did include an adolescent group, 12 to 17 adults. It included C3G or C3 glomerulopathy patients, as well as immune complex MPGN patients. Finally, it included native kidney disease, as well as transplant. The dose of steroids I mentioned to you a little bit earlier was it needed to be less than or equal to 20 milligrams per day for at least that 90-day period, so stable dosing again. And then it doesn't surprise you that they were also excluded if they had greater than 50% glomerular sclerosis. This also is actually quite common in our clinical trials these days. A number of things were also added in there. The proteinuria needed to be at least 1 gram. The GFR needed to be greater than or equal to 30 milliliters per minute, and of course, because this is a complement blocker, they needed to be on encapsulated organism vaccination. So that included strep pneumoniae, the Neisseria, AC, WY, B, etc. They needed to be vaccinated against these. And then I already mentioned that they had to be on stable, maximally dosed per the primary care nephrologist of this ACE, ARB, or SGLT2 inhibitors. A few exclusions that won't surprise you: had to have exclusion of transplant rejection, any type of chronic inflammation that may be problematic if you're going to place someone on a complement inhibitor, and essentially prior exposure to pegcetacoplan. You will see when you look across the patient populations that they were roughly the same. So you see the similar age group in them. You see a similar number of male versus female, et cetera, et cetera. I really only want to highlight a few different things. First of all, I want to make sure that you take note how many of the patients, of course, most of these patients were C3G, but there were also a decent breakdown of the immune complex MPGN patients. And of course, you can see that the transplant or the post-transplant patient population was the smallest. But again, remember, this was a placebo-controlled trial. The only other thing that I might point out just very gently to you is it did appear that the placebo group had a slightly better preserved kidney function, with their GFR being 87 as opposed to 78 in the pegcetacoplan group. So here's our primary endpoint. So first, it was log transformed ratio of urine protein to creatinine ratio at week 26. Again, that's when these endpoints are being collected. We also have key secondary endpoints of achieving a composite renal endpoint, which is greater than 50%, equal to or greater than 50% reduction in urine protein, and also a stabilization of the GFR. So that's your composite. We also collected the number of patients that actually had a greater than or equal to a 50% reduction in urine protein, change in activity score, decreased C3C staining, which you all probably know that for instance, in the C3G population, this is the diagnostic kidney biopsy, is that C3C staining. And then finally, change in GFR at 26 weeks. So let's just begin going down those endpoints, and we'll start, of course, with the urine protein. And there was a highly statistically and clinically significant reduction in the urine protein of 68.1% in the pegcetacoplan group as compared to the placebo group. Importantly, this reduction was noted as early as 4 weeks of therapy. Also importantly, this change in urine protein, you can follow down the right side of your screen, this change in urine protein was consistent across all of the patient subgroups. So you can see what the difference between the adolescent and the adult population, 74.5 versus 72.5% reduction in urine protein. And even when we get to the transplant, 67.5% reduction versus 64.9% reduction. Keep in mind, this is a later stage post-transplant group. These patients also in the post-transplant group required at least 1 gram of urine protein before they could be brought into the trial. Significantly more patients achieved a greater than 50% proteinuria reduction with the pegcetacoplan group as compared to placebo, with a 31 times higher odds ratio of achieving a greater than a 50% reduction in urine protein. Clinically, we know that that's important. There was also a substantial improvement in the percentage of patients with a proteinuria of less than 1 gram per gram in the pegcetacoplan group. This figure gets a little bit complicated, and we've tried several versions to try to simplify it for you, but let's just walk through it. So the dark blue boxes are those that have less than 1 gram. So that's the patient population that under the current guidelines, you don't escalate care. That was the reason that was chosen, and of course, that's trial entry. The gray box are those that actually have greater than 3 grams of urine protein. So that's your nephrotic range proteinuria. Those are the patients that are much more likely to have the lower albumin. What happens after 26 weeks of pegcetacoplan treatment is that you go from 8 to 51% of patients actually have now less than 1 gram of urine protein, and you drop from 38 to 14 those patients that now have 3 grams of urine protein, so nephrotic range proteinuria. As opposed to when you look at the placebo group, the 1 gram of urine protein group actually went up in the placebo group, and it was roughly stable, if you will, for the group that was in the nephrotic range proteinuria, or 3 grams per gram of urine protein. In addition, pegcetacoplan significantly stabled the estimated GFR compared to placebo. Those of you who work in the rare disease space, particularly this one, know that that's a difficult thing to do. In truth, as clinicians, what really all we want is stabilization, because the slope to loss of kidney function in this group is very significant. And in this case, we have actual stabilization of the eGFR, so a gain of plus 6.3 milliliters per minute of GFR in that 26 weeks, as compared to baseline placebo patients. And then finally, an exciting thing for those of us that work in the complement field, Again, you will recall that this diagnosis is made by C3 deposition on the kidney biopsy, right? So there generally needs to be 2 times order magnitude of C3 deposition. I showed you the complement pathway. You know that it's at the center of this disease, alternative pathway activity and collection of these breakdown products on the kidney. Pegcetacoplan treatment resulted in a clinically significant clearance of C3c, that happens to be what we detect on IF, from the renal biopsies from baseline by the time you get to 26 weeks. Very importantly, 71% of patients in the pegcetacoplan treated group actually achieved 0 staining on their biopsy at 26 weeks. Pegcetacoplan resulted in a significantly more patients achieving that composite renal endpoint. And again, to remind you, that's greater than or equal to 50% reduction in the urine protein and stabilization of the GFR. You were 27 times more likely to achieve composite renal endpoint if you were treated with pegcetacoplan. And then finally, the reduction in the activity score, the C3G histology index score with pegcetacoplan was improved. This did not meet statistical significance. Treatment emergent adverse events, their frequency and their severity were similar in both groups. You can see that across on the left and right side of your figure there. You notice there was 1 case of COVID-19 pneumonia, 1 case of influenza, and 1 case of streptococcal pneumonia in the placebo group. Again, the patient numbers, 53 in the pegcetacoplan versus 57 in the placebo. Importantly, for those of us who practice in this area, particularly using complement inhibitors, there were 0 episodes of Neisseria meningitidis in this group. And for this particular sponsor, that is consistent with what they have. You will know that they are approved in other settings. This agent is being used in other settings, and they have greater than 2,000 patient years to actually report similar data. So this is actually quite satisfying for us. So in summary, pegcetacoplan is safe and effective in this phase 3 Valiant trial. There was a proteinuria reduction of 68.1% in the pegcetacoplan group as opposed to placebo. This was across all groups: adolescent, adult, native kidney, transplant kidney, immune complex gen, C3G. There was a 50.8% of patients achieved less than 1 gram of urine protein at the 26-week mark. And there was a statistically significant stabilization of the eGFR. Finally, 0 intensity staining of C3c in greater than 70% of those exposed to this agent. And then importantly, for our patients and our clinicians alike, the medication or the agent seemed to be well tolerated with 0 meningococcal infections. I've already thanked, or I want to thank again, the patient population, but also the investigators. These trials can be very difficult to recruit to, so they all deserve to be commended. And then, of course, I thank Apellis for bringing this agent to us. And then also, we, of course, had some assistance with preparing this presentation. Thank you.
Thank you very much, Dr. Nestor. We have several questions from the audience as well. The first question is, did you observe any cases of C3 escape and worsening of disease?
Do you mean C3 escape as in what happened to the C3 as a biomarker? That's maybe what I'm not sure about. Yeah, so for instance, what is classic of the pegcetacoplan patients is their C3s will go from below normal up to actually very high. So these patients may develop a C3 that's 250 or 270 or 280, that sort of thing. In my experience with this group of patients, and we'll have to ask the sponsor if there was anyone in the trial that actually saw this, I did not see what I believe you're calling C3 escape in this group.
Thank you. The next question, Dr. Nestor, is will there be long-term follow-up of the cohort beyond 26 weeks?
Yes, in fact, there is a poster here, actually. I think it was actually here today in your 10 a.m. session. It's called the, VAIL. I should say that, right? Yeah, it's called VAIL, which is actually these patients transitioned into long-term follow-up. And so anyone that was in agreement with that will now be followed further, basically.
Thank you. And the last question we'll be able to ask today is, can you comment on how many participants were on other immunosuppression as well as other standard of care therapies, including RAS inhibitors, diuretics, and SGLT2s?
Yeah, I apologize. I don't know exactly what that answer is, but it was more than half of the patients were actually on other agents. Because the KDIGO recommendations came out well before this study was actually started. But to be fair, I'll have to actually ask the sponsor. This data is brand new, so even for myself, I'm still digging in, trying to find out all of the pieces of it.
Wonderful. Thank you very much.
Thank you, Dr. Nestor, and again, congratulations for executing a high-quality trial in a rare disease. Really great progress for all of us and our patients. The next presentation, we will go from rare to common disease. Dr. Cassie Tuttle from the University of Washington and Spokane, Washington, will present semaglutide reduced risks of major kidney outcomes, irrespective of chronic kidney disease severity in the FLOW trial. Cassie, please.
Well, thank you very much. It's truly a pleasure to tell you more about FLOW this morning. And like the previous presenters, this is clearly team science, and this was done by a group of investigators that you see listed there. Today, I'll be telling you about the results stratified by CKD severity. Here are my disclosures, and the FLOW trial was sponsored by Novo Nordisk. We have previously reported that semaglutide reduced the risk of major kidney outcomes, cardiovascular events, and death from any cause in participants with type 2 diabetes and CKD. In this analysis, CKD outcomes were assessed by baseline CKD severity in the FLOW trial. Just to remind you of the design, it was a multinational, randomized, controlled clinical trial. It was a classic population with type 2 diabetes. They were required to be on an ACE inhibitor or an ARB if tolerated. The GFR could be as low as 25 and as high as 75. If the eGFR was 50 or higher, the UACR had to be at least 300, but we allowed people with a UACR as low as 100 if the GFR was 25 up to 50, and we excluded people with more than 5,000 milligram per gram. They were randomized 1-to-1 to either once-weekly subcutaneous semaglutide at a dose of 1 milligram plus the standard of care versus placebo plus the standard of care. This was an event-driven trial, and at an interim analysis, early cessation of the trial was recommended by the Data Safety Monitoring Board because of clear positive efficacy. So at the interim analysis, we had 570 events. The primary outcome was a reduction of estimated GFR, 50% or greater compared to baseline, or kidney failure defined by a persistent reduction in eGFR to less than 15, or initiation of some form of chronic kidney replacement therapy, either dialysis or kidney transplantation, as well as kidney death and cardiovascular death. For this analysis, we categorized individuals by baseline eGFR and UACR, less than 30, 30 to less than 45, 45 to less than 60, or greater than or equal to 60, and albuminuria categories less than 100, 100 to less than 300, 300 to less than 1,000, 1,000 to less than 2,000, or greater than 2,000. So quite granular albuminuria categories. I'm now going to show you the baseline characteristics by these categories. What I would point out to you is that in the groups with lower GFR, they tended to be older. They also had a longer duration of diabetes. Albuminuria was higher. ACE or ARB use was lower, as was SGLT2 inhibitor use, whereas insulin use was higher in the group with lower GFR. By albuminuria, we'll look the other way for severity. These patients with higher albuminuria tended to be younger. They too had a longer duration of diabetes, a lower GFR. ACE/ARB use was fairly consistent across the groups, but again, SGLT2 inhibitor use dropped off with greater severity defined by albuminuria. Here's the primary composite outcome for the overall cohort, an event rate of 23% in the placebo group and about 19% in the semaglutide group for a hazard ratio of 0.76 and highly statistically significant. Here are the time to event analysis by the GFR categories: less than 30, 30 to less than 45, 45 to less than 60, and greater than 60. Across the board, we see consistent hazard ratios. This is now shown in a forest plot here with the p-value for interaction at 0.832, reflecting consistency and benefit irrespective of high to low GFR. Below, you'll see individual components of the primary outcome: kidney replacement therapy, GFR less than 15, persistent reduction in GFR to less than of 50 or greater, or CV death. And again, there's consistency across GFR strata for all of these outcomes, again reflected in non-significant interactions by strata. Now for the UACR, shown in a similar type of forest plot. Here is the overall hazard ratio, 0.76, and from the lowest to the highest albuminuria category, we could see consistent hazard ratios without interactions. So again, consistency across albuminuria categories. For the primary outcome, we see the same for individual components: kidney replacement therapy, GFR decline more than 50%, or CV death. The reason GFR less than 15 is not shown is there were too few patients in some of the cells to perform an analysis. When we look at serious adverse events by GFR, what I'll point out to you is across the board, from low to high GFR, we do not see any signal of differential effect, except across the board, there were fewer infections, which is even maintained in the lowest GFR group, and fewer cardiac disorders. So in conclusion, semaglutide safely reduced risks of major kidney outcomes irrespective of CKD severity, whether defined by eGFR or albuminuria in participants with type 2 diabetes and CKD. So again, we iterate that semaglutide saves kidneys, and I will add hearts and lives. And then we want to say a big thank you to all of the trial participants, the investigators who conducted this clinical trial during a worldwide pandemic, our steering committee, a global expert panel who helped all of the regions of the world stay on task with this trial, our data monitoring committee who gave us very good advice, as well as the adjudications events committee that made our outcomes rigorous and reliable. Most importantly, this presentation is dedicated to the late, great George Bacris, who was with us the whole time. He died shortly after we reported the primary results, and we dedicate this presentation to him and remember him with fondness and much gratitude. Thank you.
Thank you, Dr. Tuttle, for an excellent presentation. We have several questions from the audience now. The first is, can you report on the degree of weight loss across the eGFR strata?
It was consistent across the eGFR strata too. So overall, the weight loss was about 4 kilos. That's the placebo-corrected difference. So it was 5 in the sema group and 1 in the placebo group. And they started at about 90 kilos. So we have reiterated this is not a weight loss study. We started this in 2019 before these were conceptualized as weight loss drugs. The dose was 1 milligram. And we did not see a differential effect on weight, although that has not been rigorously analyzed. There's been no signal that it differs by GFR.
Thank you. The next question is, would you expect oral semaglutide to have the same efficacy? If yes, why was the subcutaneous route chosen?
Well, I think we can't answer that question because we didn't do the experiment. The SOUL trial has just reported its top-line results, a cardiovascular outcome trial with oral semaglutide, and they did show a 14% relative risk reduction in MACE events. There will be kidney outcomes reported. So I think we wait for those studies. But at the time we started this study, the injectable form was the form that was available.
Can you comment on the difference in effect size that was observed in the North American group?
I think we don't know the reason for that. The study was not powered to look at those subgroups. And so, again, we would caution about looking at individual subgroups and focus on the lack of interaction and the overall positive results. People have speculated, this has been seen in other trials where different regions of the world may not show the same results, but usually that turns out to be something related to methodology. And I think we can still conclude that no matter where in the world you live, you probably will have a consistent effect of semaglutide.
Can you comment whether a blood pressure effect was observed with the study drug?
Only small, a few millimeters of mercury. I believe it was about 3. That's very consistent with the class. And again, these effects are far beyond anything we've ever seen in a hypertension trial. So while there may be some benefit of improving risk factor control, glycemia, weight, blood pressure, they're very minor effects. And in mediation analyses conducted by one of my colleagues, Professor Mon in the front row there, previous trials, for example, in the CVOTs with liraglutide looking at the secondary kidney outcomes, in mediation analysis, only about 25% of the effect was attributable to risk factors. And the rest was presumably direct effects of the medicine.
Can you also comment on what the observed effects were in patients also on SGLT2 inhibitor therapy?
Yes, we have actually, that was a pre-specified analysis. The paper was published in Nature Medicine in June. And again, we see consistent effects when we look at GFR. It's important to realize that only 15.6% were on an SGLT2 at baseline. It went up to about 33% during the trial, with more in the placebo group. Also, because the cell sizes are so small, we have to look at GFR outcomes. There are too few events to make valid comparisons other than looking at GFR. And the GFR change, whether by cystatin C or creatinine, is exactly the same. At 2 years, it's about 3 ml per minute different, whether or not a person is on an SGLT2 inhibitor. So this is consistent with, more likely than not, an additive effect of these agents.
Can you also comment on the dose that was used, the 1 milligram dosing? Would you recommend alternative dosing regimens that are used for weight loss?
Well, I know I feel like I'm saying the same thing over and over again. This started in 2019 before these were weight loss drugs. We used the dose that had been used for hyperglycemia at 1 milligram. We have strong, consistent results with that dose. Whether higher doses will be more beneficial is to be determined, and there are studies using either double or triple agents that may be more potent. Higher doses, for example, in weight loss studies. There will be more weight loss, and perhaps then weight will contribute in a bigger way to not only the kidney protection, but the cardiovascular protection. But those studies need to be done. I think they're important questions to ask. But I think even now we can be confident 1 milligram's good. Whether more is better remains to be determined.
Can you comment on the effect of the study drug on proteinuria as an outcome, please?
Yes, there was about a 40% reduction in albuminuria. That was in the main paper as well.
And a follow-up question, can you comment on whether the effect size differed in those with less proteinuria?
No, that's what we just showed you. In the forest plots of the UACR, and I'm happy to make the slides available, whether we look at the primary outcome or the components of the primary outcome, the results were consistent from lower levels of albuminuria to higher levels of albuminuria. And I think the inference is that all patients who would be similar to people in flow, irrespective of albuminuria or GFR, are likely to benefit in terms of hard outcomes. And so we need to use these agents, and we need to use them in most patients.
And the final question, can you comment on potential in type 1 diabetes?
Yes, actually, the type breakthrough T1D, which used to be known as JDRF, has actually funded a clinical trial to test semaglutide in the 1 milligram dose in type 1 diabetes, and I'm pleased to be involved along with other colleagues in that trial, and we are enrolling now, and so stay tuned because we'll come back to you with some data in a year or two.
Wonderful. Thank you so much, Dr. Tuttle.
Thank you much, Kathy, and also thanks a lot for dedicating the presentation to the memory of George. He is dearly missed. The next presentation will be from Dr. Laura Demba from the University of Pennsylvania on pain coping skills training for patients receiving hemodialysis, a HOPE Consortium randomized clinical trials. So moving from pharmacological interventions to behavioral interventions and pharmacological. Laura, thanks a lot for presenting.
All right, well, thank you very much. I'm sorry, it's not moving forward. There we go. Here are my disclosures. On behalf of the full group of authors, I'm pleased to present the results of the HOPE Consortium trial. The HOPE Consortium was funded by the NIH HEAL initiative with oversight provided by the NIDDK. The charge to the HOPE Consortium was to design and conduct a multi-center randomized controlled trial evaluating behavioral and pharmacologic approaches to reduce pain and opioid use among people receiving treatment with maintenance hemodialysis. The rationale for funding such a trial is that pain is common in this patient population and it's challenging to treat. The design of the trial is shown here. Participants were randomized in equal proportions to either a cognitive behavioral intervention called Pain Coping Skills Training, or PCST, that was adapted for hemodialysis, or to usual care where there was no trial-driven approach to pain management. The intervention was administered for 24 weeks, and the participants were followed for 36 weeks. At week 24, the subset of participants who were taking full agonist opioid pain medications were eligible to participate in an exploratory evaluation of a pharmacologic agent. This presentation will focus on the results of the behavioral intervention. The Pain Coping Skills Training intervention had 2 components, each lasting 12 weeks. The first component consisted of one-on-one weekly coach-led sessions that lasted about 45 minutes. They were delivered via video conferencing, and they used cognitive behavioral therapy and motivational interviewing to increase self-efficacy and skills for coping with chronic pain. The second component of the intervention was a more novel component, and this was automated interactive voice response sessions that were designed to help the participants maintain the skills that they had acquired during the first 12 weeks. The IVR sessions were 5-minute interactive telephone sessions that included customized messages, asynchronous weekly coach feedback, and access to skill refresher resources. We enrolled people with chronic pain that was moderate or severe. They could be English or Spanish speaking, and they had to have been receiving treatment with maintenance hemodialysis for at least 90 days. We excluded people with active opioid use disorder or significant cognitive impairment. The primary outcome was pain interference, which means the extent to which pain affects activity, mood, and relationships. And we ascertained this using the Brief Pain Inventory, or BPI, interference subscale. This is a well-established and widely used outcome measure for pain trials. We had several secondary patient-reported outcomes that addressed other aspects of pain, as well as conditions that commonly coexist with chronic pain and quality of life. And we had secondary clinical outcomes, falls, hospitalizations, and death. The patient-reported outcomes were ascertained by a centralized team that otherwise had no interaction with the trial participants. They were ascertained at baseline, week 12, week 24, and week 36. The primary analysis was based on the change from baseline to week 12. We enrolled participants at 16 sites, and here is the enrollment plot. We met the target for 640 randomized participants, and we met the target a few months ahead of schedule. The baseline characteristics were well balanced across the randomized groups, and we were pleased that the demographic characteristics of the trial cohort were similar to those of the overall US hemodialysis population, with the exception that we had an overrepresentation of Black race among the trial cohort relative to the overall US hemodialysis population. There was excellent adherence to the intervention, with a per participant mean of 10.4 and a per participant median of 12 completed coach-led PCST sessions. This was out of a maximum of 12 sessions. Okay, so now for the results of the primary outcome. The BPI interference score can range from 0 to 10, with higher scores indicating more pain interference. At week 12, which was the pre-specified time point for the primary analysis, there was a decrease in the BPI interference score of 1.19 points in the PCST group compared with 0.71 points in the usual care group, generating a between group difference using mixed effects models of 0.49 with a p-value of 0.009. The effect was similar at week 24. At week 36, the effect was in the same direction, but it was smaller in magnitude and no longer statistically significant. We performed a pre-specified responder analysis to compare the proportion of participants in the two randomized groups who had a clinically important improvement in pain interference. So for the BPI interference instrument, it has been established that a 1-point change is a clinically important difference or clinically important change. So what we found was that at week 12, 50.9% of participants in the PCST group compared to 36.6% of participants in the usual care group had a greater than 1-point decrease in the BPI interference score, or a clinically important effect. This is an odds ratio of 1.79, an absolute difference between the groups of 14%, a relative difference of 40%, and a number needed to treat of 7. The between group difference was similar at week 24. At week 36, the difference was smaller and not statistically significant. This slide shows the secondary patient-reported outcomes. What's shown on these plots are the mean values at each of the time points, with the baseline value at the left moving over to week 36 on the right. The purple lines are the intervention group. The orange lines are usual care. And what we found was that for pain severity, for quality of life, for depression, and for anxiety, there was a greater improvement in the intervention group than in the usual care group at weeks 12 and or week 24. For pain catastrophizing, there was a greater improvement in the intervention group than the usual care group at weeks 24 and at week 36, 12 weeks after the intervention had ended. There were no differences between the groups in the secondary clinical outcomes, and there were no differences in the adverse events between the groups. So to summarize, a pain coping skills training intervention adapted for hemodialysis decreased pain interference compared with usual care among hemodialysis patients with moderate or severe chronic pain. Benefit was evident at the end of the initial 12-week period of coach-led sessions and at the end of the subsequent 12-week period of IVR sessions, but was diminished at week 36. The intervention resulted in a clinically meaningful improvement for a substantial proportion of participants. The benefits were also apparent for the secondary outcomes of pain severity, pain catastrophizing, depression, anxiety, and quality of life. In our view, the efficacy, the acceptability to patients, and the safety of the intervention support future work to develop strategies for adopting pain coping skills training in dialysis clinical care. We were extremely fortunate to have a highly engaged group of patient advisors who worked with the consortium from the very beginning of when the consortium was formed all the way until the end of the trial conduct. Their contributions to developing the intervention, the implementation approach, and the recruitment materials were key to the success of the trial. And in particular, they were key to ensuring that we evaluated an intervention that was viewed by patients not only as acceptable, but also as important. In addition to the patient advisors, I want to acknowledge the full group of HOPE Consortium investigators, the research coordinators, the PCST coaches, the outcomes ascertainment team, the intervention fidelity monitors, the trial participants, the dialysis providers that facilitated the implementation of the trial in their facilities. And this is particularly notable because we launched the trial during the first year of the COVID pandemic, which was a very difficult time, as everyone knows, for dialysis providers. I want to thank our external data and safety monitoring board and our highly engaged NIDDK project scientist, Paul Kimmel, and project officers, Kevin Abbott and Tracy Rankin. Thank you.
Thank you, Dr. Dember, for an excellent presentation. We have several questions from the audience. First, can you talk about the etiology of pain? Did you look into that further and also look at the effects of other pain medications that were used, such as neuropathic medications?
Yes, we characterized the types of pain at baseline, and there actually was a poster, I think on Thursday, led by Michael Fisher, that showed the types of pain in the participants. They were similar in the two groups, and they were actually on the baseline. I think they were on the baseline characteristics slide, but there were a variety of types of pain, and this is not surprising because that's what we kind of know about pain in the patient, this patient population. A lot of musculoskeletal pain, a lot of neuropathic pain, some vascular access pain, some other types of vascular pain, but I'd say the predominant type was musculoskeletal. But there were many patients who had multiple types of pain. The second question was the effect of medications. We've characterized the medications, and we haven't yet done analyses to try to understand if types of concurrent medications might have modified the effect of the intervention, for example. We allowed, management of pain medication to be managed by the treating clinicians. We did not protocolize that in any way.
As part of those further analysis, will you be looking at the use of pain medicine over time with your intervention as well?
We could do that. We hadn't thought of that specifically, but we definitely can because we, on a monthly basis, we updated the medication, the medications that were being used. So we could do that.
Can you talk about the training of the coaches? Was this standardized and as well as the sessions themselves?
Yeah, there was a lot of effort that went into the training of the coaches. So we had 5 coaches. It was a centralized team of coaches, which was also a very nice feature of this. We did not need coaches at every enrolling facility. And there were 16 centers that enrolled, but there were many more dialysis facilities at which people were getting their care. And the sessions, I didn't say this, but the sessions were, it was up to the participants, but they could have the sessions during their hemodialysis treatments or they could have them at home. 2/3, I think, of the participants chose to do it during dialysis. But the coaches were trained by a group of the investigators in the HOPE Consortium who were psychologists, health psychologists, and pain experts. And they were trained before they started to implement the intervention, and they met regularly throughout the course of the trial to keep that training and that kind of standardization going. We also had an independent group of fidelity monitors who reviewed a certain percentage of the sessions. The sessions got recorded, so they reviewed a certain percentage of the sessions by each of the coaches and kind of throughout the course of the trial to using a very structured approach to ascertain fidelity to the intervention, and the fidelity was quite high. I don't know if that answered everything there. I think I did, yeah.
Another question about the durability of the intervention. 2 parts to that. One, what do you think caused the decrease at 36 weeks? Does that mean a refresher would be needed?
That's my interpretation. There was a lot of engagement, obviously, during the first 12 weeks with the weekly sessions with the coach, and then these IVR sessions, which was, as I said before, a relatively novel component of the intervention. But if people were sort of interested and willing to do it, it provided a lot of engagement, kind of not directly with the coach, but indirectly with the coach through the kind of asynchronous feedback that they would get. But then it stopped at week 24. So I think it makes sense. I mean, the interpretation that the person asking the question would be similar to my interpretation. And I think, a next step might be to think about what could be done to prolong the effects of the intervention.
Will you be observing the patients beyond the 36-week observation period?
No, the follow-up ended at 36 weeks, so we will not be able to get information beyond that.
Can you talk about how this intervention could potentially be rolled out in clinical practice?
Yeah, that's a very important question, and it's something we're thinking a lot about. And I think, there are certain aspects of this intervention that help facilitate a larger rollout, which is that the intervention was successfully implemented using a centralized approach. There were no in-person contacts, physically in-person contacts between the participants and the interventionists. So that has the potential for a larger rollout. But it does require a team of coaches, and it requires follow-up. So we're thinking about, I think the next step is to really do some type of large implementation type evaluation to understand what the facilitators and barriers are to implementation, but really thinking about it from an implementation lens.
Great. Another question. What was the intervention response like in your non-English speaking participants?
Yeah, so we had about close to 10% of the participants spoke primarily Spanish, and their intervention was administered in Spanish. Their ascertainment, the PRO, the patient-reported outcome ascertainment, was conducted in Spanish. We looked for effect modification by a variety of demographic characteristics, and there was not statistically significant. The p-values for the interactions were not statistically significant for any of the demographic characteristics, but I will say that there was a hint, it was the one that was closest to being statistically significant, of a greater benefit among the Hispanic, not Spanish speaking, but Hispanic participants. So a subset of those were Spanish speaking, but not all of them.
And last question, Dr. Dember, do you think that this could be rolled out directly into dialysis units themselves as part of your implementation strategy?
That would be the goal, yeah.
And maybe final comment on the cost effectiveness of such an intervention?
We did not evaluate cost effectiveness, but it's an important question. But yeah, we did not. I can't really comment on that.
Excellent. Well, thank you so much.
Thanks, Dr. Dember, for the behavioral trial strategies presented. We are now transitioning to the device segment of our high-impact clinical trial session with a presentation from Dr. Hussain from the Brigham and Women's Hospitals from Boston on prospective randomized trial of Humacyte's acellular tissue-engineered vessels versus autologous arteriovenous fistulas for hemodialysis access. Dr. Hussain, please.
Thank you. Good morning, everybody. So we'll change gears and talk about dialysis access. Thank you to the Society for giving us the opportunity to present top-line results from the Humacyte V007 trial. Here's a list of my disclosures, and the sponsor is Humacyte for this trial. So AV fistulas are a preferred method for vascular access in many patients requiring hemodialysis access. However, AV fistula maturation is a real issue, and failure of AV fistulas can drive increased catheter use and associated morbidity with catheters, such as infections, central venous stenosis, as well as mortality. ATAV, or acellular tissue-engineered vessel, is a potential alternative vascular option for AV fistulas, with preliminary data demonstrating low infection rates and without the associated maturation failure. So what is ATAV? ATAV is a human-engineered vessel that is grown from a bank of human cells. Briefly, Aortic smooth muscle cells are seated in a biodegradable scaffold. These cells are then stimulated with biochemical and mechanical forces, and the vessel is generated in a bioreactor bag. After 2 months, the vessel is decellularized, leaving behind a collagen tube ready for human implantation by the surgeon. ATEV is available off the shelf and carries a shelf life of 18 months. After implantation, ATEV is infiltrated with host cells and remodeled by the host, much like native vascular tissues. These unique properties of ATEV make it more infection resistant and potentially more durable than alternative vascular conduits. So we designed a prospective, multi-center, open-label, randomized 2-arm comparative study. 242 ESKD patients who were on hemodialysis and eligible for AV fistula or AV graft creation across 30 centers in the US were randomized in a 1-to-1 ratio to the ATEV or autogenous traditional AV fistula, which were implanted in the upper extremity. All patients in the study were followed for at least 24 months. Here's the key inclusion criteria. Adults with ESKD receiving hemodialysis who were eligible for AV fistula or AV graft creation. The key exclusion criteria was candidates who are able to get the optimal fistula. So this was defined as a first-time, one-stage, 4-arm radiocephalic AV fistula with an excellent artery more than 3 millimeters and excellent vein more than 3.5 millimeters. The co-primary endpoints for this trial were functional patency at 6 months and secondary patency at 12 months. Functional patency was defined as continuous dialysis with 2 needles for at least 3/4 of a session or a continuous 4-week period. A key secondary efficacy outcome was duration of access use in the first year. And we looked at several safety outcomes. These included infection, other adverse events, as well as access-related interventions over the first year. So, a total of 346 patients were screened. 242 were randomized in the trial, 123 to the ATEV group, and 119 to the AV fistula group. Follow-up was 90% at 6 months, 80% at 1 year, and 2-year follow-up is currently ongoing. Here's a look at the baseline characteristics of the cohort. You can see the mean age was 57 to 60 years in both groups. About 1/3 of the patients were over the age of 65. 30% of the patients were female. 35 to 40% of the patients were obese with a BMI greater than 30. 2/3 of the patients were diabetics. And mean amount of catheter time prior to randomization was just over 4 months. Here's a look at the configuration of the surgical accesses implanted in the trial. You can see in the AV fistula group, 3/4 of the patients got an upper arm AV fistula, and 1/4 got a forearm AV fistula. In the ATEV group, 60% of the patients got the conduit placed in the upper arm, and 40% in the forearm. Here's the top-line results from this study. Functional patency at 6 months was 81% in the ATEV group and 66% in the AV fistula group. Secondary patency at 12 months was 68% in the ATEV group and 62% in the AV fistula group. The p-value was highly statistically significant at 0.0071 for joint relative patency in favor of ATEV. Subgroup analysis for the primary outcome identified 3 high-risk subgroups which benefited from ATEV the most. These subgroups were as follows: patients who had a history of diabetes, patients who were obese with a BMI greater than 30, and female patients, which actually had the strongest signal for efficacy with ATEV compared with AV fistulas. Now let's look at the duration of access use over the first year. You'll see in the overall cohort, patients who had ATEV used the access for a mean of 7.5 months compared to 6 months in the AV fistula group. Looking at our high-risk subgroups again, female patients who were randomized to ATEV used the access for just over 8 months compared with 5 months for those randomized to AV fistula. In the obese subgroup, patients who received ATEV used the access for just over 7 months compared with 4.5 months who were randomized to the AV fistula group. And in diabetics as well, use of ATEV was longer compared with AV fistulas. Now let's look at some of the safety outcomes. First, infection rates. Infection rates were similarly low in the ATEV group and in the AV fistula group. When looking at all hemodialysis access-related infections, meaning not just surgical infections, but also catheter-related infections, the rates were 9.1% in the ATEV group and 9.9% in the AV fistula group. And when you break these down by bloodstream-related infections versus local infections, these were 5% and 4% respectively in both groups. Specifically, surgical access-related infections were very low, 3% in the ATEV group and 1% in the AV fistula group. Looking at other outcomes of special interest, rates of thrombosis, stenosis, and pseudoaneurysm were generally higher in the ATEV group compared with the AV fistula group. True aneurysms are very low, 2% in both groups. There were no ruptures in the ATEV group and 2% in the AV fistula group. Rates of steal or access-related hand ischemia was higher in the AV fistula group, 5.8% compared with 0.8% in the ATEV group. Majority of the thrombotic events that did occur in the ATEV group were successfully treated. 87%, in fact, of the 126 thrombotic events were successfully treated with intervention to maintain secondary patency in the ATEV group. Now here's a look at the reinterventions. Not surprisingly, angioplasty, stenting, and thrombectomy was higher in the ATEV group compared to the AV fistula group. On the other hand, balloon-assisted maturation to mature the axis was more likely needed in the AV fistula group, 6.6% compared with none in the ATEV group. And surgical revisions were also more common in the AV fistula group, 23% compared with 10% in the ATEV group. So in summary, ATEV, or acellular tissue injury in vessel, is superior to AV fistulas with respect to 6-month functional patency, 1-year secondary patency, and 1-year access usability in ESKD patients requiring hemodialysis access. Outcomes with ATEV are most improved in the high-risk subgroups. These are patients, it's very difficult sometimes to create a fistula and mature a fistula. These subgroups were females, obese patients, and diabetic patients. ATEV had a comparable safety profile to AV fistulas. There were similar rates of infections in both groups. There was a lower need for maturation and surgical revision procedures with ATEV. There were more thrombotic and stenotic events in the ATEV group that required maintenance interventions. However, the majority of these cases were successfully treated. For the future, we look forward to the Humacyte V012 trial. This is a phase 3 multi-center prospective randomized controlled trial of ATEV versus AV fistula, specifically in female patients with ESKD on hemodialysis, and this trial is currently enrolling. We'd like to thank all of the patients, as well as all of the collaborators and the surgical teams and the sponsor for making this trial happen. Thank you very much, and happy to take any questions.
Thank you so much, Dr. Hussain. We have several questions from the audience. The first is, can you comment on the choice of using an AV fistula as your control group rather than a graft?
Yes, of course. There has been some preliminary studies done using ATEV versus PTFE, which is traditionally the prosthetic graft that we use, which showed excellent performance of ATEV compared to PTFE. So naturally, the next step is to see how does it perform with the gold standard, which is AV fistulas. And I think really what's interesting is its performance in high-risk patients, so those diabetic female patients, as well as obese patients, in which AV fistulas, although they're gold standard, can sometimes be very hard to create because of anatomical factors, small vessels, high risk of infection. So I think those are the main reasons that this was an important control group to compare the ATEV against.
Can you comment on the findings by gender and why, if the gender findings were unexpected or not?
Yeah, I think those are very interesting. And as a surgeon who often plans and does several access procedures, I think the sex-based differences are very important. You know, women we know have smaller vessels. They have smaller radial arteries to start with. They often also have smaller cephalic veins. You add a couple more risk factors, you know, older age, obesity, and the outcomes of AV fistula can be very poor and difficult to mature and maintain fistulas. So I think in the female subgroup, this is potential technology that can have a really a big impact for our patients, and that's why the sponsor is doing a randomized trial only in female patients. There were only 30% female patients in this trial, so I think those will be very important results to see.
What was the patient experience with ATEV?
Great question. So again, these are fresh data, and we haven't gone through all the qualitative outcomes yet. But I would say there are some differences with respect to cannulation of the ATEV compared to a traditional PTFE graft. So generally speaking, when a dialysis unit sees an ATEV, they think it's a graft, it's a PTFE. They expect that pop when they cannulate the conduit. But really, it's much softer. It's more like a vein. So I think because some of the thrombotic events may have been because of difficulty with cannulation, backwalling, because some of the cannulators may have been more aggressive in trying to get into the conduit compared to a PTFE. So there's certainly more work to be done in terms of training cannulators and dialysis unit. A lot of that was done within the trial, but as you all know, there's still a lot of variability despite trying to train multiple different dialysis units to ensure they can treat this more like a vein than a graft to minimize sort of those back walls and infiltrations and hematomas.
Was aspirin or other anticoagulation used in either group?
Yes, so antiplatelet was actually mandated to be in the trial. At minimum, if patient was on no antithrombotic medication, aspirin 81 was required. If the patient was already on other antithrombotic medications, such as a P2 inhibitor or anticoagulation, then additional aspirin was not mandated.
Can you comment on the blood flow rates that were achieved with ATEV?
Yeah, good question. And again, like I said, fresh data. We still haven't gone through all the cannulation data and then flow data. But overall, what I would say is AV fistula use was adjudicated and was successful, and the flow rates that were achieved were similar to grafts or fistulas. And what was really interesting to me, again as a surgeon, was the rates of steal was actually lower in the ATEV group, meaning although many of the patients were getting upper arm AV fistulas, which we know can get really high flow right quickly, the ATEV flow was a little bit more modulated perhaps because the rates of steal were only 1% in the group.
Did you perform any subgroup analyses by age?
We have not done a subgroup analysis by age yet, but certainly a very important recommendation and something we will be looking into.
Were there any technical requirements for the vascular surgeons who performed the procedures, and how did you standardize this across sites?
Yes, excellent question. As somebody who actually put these in, you know, one of the things was important to know, these come in a standard size. So it's a 6 millimeter in diameter vessel and 42 centimeters in length. And there were some instructions given to the vascular surgeon. It was very basic. You know, they come in this bioreactor bag in which the vessel has grown. And essentially, we had to cut the bag, drain the fluid, and it had a mandrel inside. And the key thing was to tunnel the graft with the mandrel in to prevent kinking of the conduits, which is relatively straightforward. It felt like a vessel, more so it was soft, as surgeons were used to doing that, and certainly it would be a surprise to some of the folks who were expecting more like a PTFE feel, but this felt more like a soft vein, and certainly the surgical technique we used was similar to things that we usually do in dialysis access-related procedures.
Excellent. Thank you so much, Dr. Hussain.
And the last presentation of our session is from Dr. Chi-Chi Hang from the Kaohsiung Medical Center at the University of Taiwan on efficacy and safety of dapagliflozin in patients with chronic kidney disease stage 4 to 5. Dr. Hang, please.
Thank you. Good morning, everyone. I'm Chi-Chi Hong from Taiwan, the chief primary investigator of this trial. I'm very happy to present our data here. On behalf of all investigators, I would like to thank ASN for the opportunity to present our data in this meeting. And this is an investigator-led randomized control trial. This is my disclosure. The first question is, why did we conduct a clinical trial in CKD stage 4 and 5? CKD stage 4 and 5 were generally excluded in most clinical trials. Only recently, some trials extend the range of eGFR down to 20 milliliter per minute. For patients with eGFR 20 and an average annual eGFR decline rate of 2.5, it still takes 4 to 6 years to dialysis initiation. Depends on early or late dialysis initiation. However, limited prospective trials have been conducted in these patients, such as low-protein diet ACE inhibitor, or even STOP ACE inhibitor, or multidisciplinary care. Besides, CKD stage 4 and 5 patients are at high risk of cardiorenal syndrome, complicated by acute kidney injury and heart failure. These patients with eGFR less than 20 were also not included in cardiovascular or heart failure trials. There were 3 well-known renal outcome trials of SGLT2 inhibitor. CREDENCE study includes diabetic kidney disease patients. The second DAPA-CKD trial also included non-diabetic kidney disease. And the EMPA kidney trials extend the eGFR range down to 20. So our trials included patients with eGFR 10 to 30 and without the limitation of UACR. So this is our study design. Besides the range of eGFR, we also selected patients with rapid renal progression with an slope more than 2.5, and also select patients with basic understanding of ESKD. The exclusion criteria were simple: lupus nephritis, ANCA vasculitis, urinary tract obstruction, and frequent urosepsis. We enrolled 180 participants and randomized them in a 2-to-1 ratio into treatment group and control group, stratified by diabetes, baseline eGFR, and baseline eGFR slope. In the control group, they received integrated CKD care, which we have published previously to intensify the low protein diet control or lifestyle control and drug compliance. In the treatment group, they received dapagliflozin 5 to 10 milligrams. And we start titrate from 5 milligrams to prevent acute eGFR dip. And after a median follow-up of 1.62 years, we studied the outcome. The primary outcome is a surrogate renal outcome, the total eGFR slope. And there are 3 secondary outcomes in a hierarchical testing sequence. First, renal composite outcome included sustained more than 50% decline of eGFR, chronic dialysis, eGFR less than 5, and renal or CV death. Second, renal and heart failure outcome was previous outcome plus AKI or heart failure hospitalization. Third, renal and CV outcome was previous outcome plus 5P mass, which was stroke, myocardial infarction, unstable angina, hospitalization, coronary or peripheral artery revascularization. We selected surrogate renal outcome because at that time, when we designed this trial, the estimated hazard in CKD stage 4 subgroup was around 0.6 to 0.7. 7, we feel the hazard may be a little bit not so good as the earlier stage. So it may take more than 400 or 500 participants to accelerate the result, and because the limited budget, so we choose the surrogate outcome as our primary outcome. And the baseline characteristics of these patients, the age was 69, body weight 67 kilogram, eGFR 90 milliliter per minute, eGFR slope minus 5.4 milliliter per minute per year, and UACR 700 milligram per gram. And there were 79% of female, 53% of diabetes, 31% of cardiovascular disease, 11% of heart failure, and 52% of RAS inhibitor users. And in the treatment group, 58% titrate dapagliflozin up to 10 milligram. The other variables were also comparable between two groups. And in comparison with DAPA-CKD and EMPA-KIDNEY trials, we have to notice that our patient had a smaller body weight and lower eGFR. And the percentage of diabetes and the UACR were less than the DAPA-CKD trial, but more than the EMPA-KIDNEY trial. So let's look at the primary outcome. This figure shows the least squared eGFR difference in the control group. And the total eGFR slope calculated by the linear mixed model was minus 3.58. In the dapagliflozin group, the total eGFR slope was minus 2.37, and the slope difference was 1.21, which was significant with p-value 0.019. And we have also to mention that in these two groups, the total eGFR slope were also better than their baseline eGFR slope. So let's go on to the secondary outcomes. First, the renal composite outcome. There were 21 events out of 60 participants with 35% event rate in the control group, and 24 events in 120 participants, that is 20% event rate in the dapagliflozin group. And the Cox proportional hazard model stratified by diabetes, eGFR, and baseline eGFR slope by the intention to treat analysis, we found the hazard ratio was 0.423. It was significant. So we go on to test the next outcome. The next is renal and heart failure composite outcome. And again, the event rate in the control group was 21. And in the DAPA group, it were 26 events. And the hazard ratio was 0.456. It was also significant. So we go on to the last outcome, the renal and cardiovascular composite outcome. In the control group, the events were still 21 events. And in the DAPA group, the event were 29 events, and the hazard ratio 0.531. it was also significant. And the subgroup analysis of the renal composite outcome were no difference between different age, sex, type 2 diabetes, and systolic blood pressure. I'm sorry, the 95% line disappeared in this computer. And there were also no difference between CKD stage, overhydration, or RAS inhibitor users. And you may notice that in the UACR less than 1,000 milligram per gram subgroup, it seems a little bit better, but the P4 interaction was 0.06, not significant. When we go on to the safety outcomes, there were no difference in serious adverse events or adverse events of interest between two groups. We have to mention that even under the careful titration from 5 milligram, there were still 2 participants with acute EGFR dip more than 30%, and one of them stopped the medication. We also report the CKD complications of interest because previous study demonstrated SGLT2 inhibitor may be better in hemoglobin, potassium, or uric acid. However, in this trial, we did not find a difference in the incidence of anemia, hyperkalemia, and hyperuricemia. And last, I have to talk about the non-fatal serious adverse event in those with renal heart outcomes. In those with heart outcomes, it was 17 participants in each group. And we can find in the control group, there were 7 AKI episodes just before the heart outcome. So in these patients, AKI is not only AKI, it almost equals to dialysis. And the serious adverse event in the time to event analysis were also no difference between groups. So, summary, DAPA ADVKD trial is the first SGLT2 renal outcome trial to include patients with EGFR less than 20. In patients with CKD stage 4 and 5, dapagliflozin plus integrated CKD care compared to integrated CKD care alone improve total EGFR slope, improve composite renal outcome, and improve composite renal and heart failure outcome, and also renal and cardiovascular outcome. Dapagliflozin was found to be safe in patients with CKD stage 4 and 5. And finally, I would like to thank all the patients and their families and our committee members, especially Professor Shangzhi Huang, and all the investigators and the supporters from AstraZeneca, Ministry of Health and Welfare, and Kaohsiung Medical University. Thank you for your attention. I'm happy to take any question.
Thank you so much, Dr. Hung. I'd like to invite Dr. David Wheeler from the University College of London to come up and be a discussant for this presentation.
Well, thank you very much to the ASN for inviting me to give a commentary on this presentation. And Dr. Hung and colleagues, congratulations on helping to fill an important knowledge gap. My disclosures have been presented, but are also on this slide. So if we look at the current KDIGO guidelines on the management of patients with chronic kidney disease, and these were updated just this year, 2024, we see recommendations for treating patients with type 2 diabetes and CKD with SGLT2 inhibitors. We see recommendations for treating patients with chronic kidney disease who have albuminuria with SGLT2 inhibitors, regardless of their diabetes status. And we see recommendations for treating patients with heart failure, irrespective of their level of albuminuria, with CKD with SGLT2 inhibitors. And these are both 1A recommendations, as you will see. But there's a caveat here. These recommendations apply to patients who have eGFRs of greater than 20 mils per minute. And as we've heard already from Dr. Hung, this is largely because the trials that we have conducted in these patients, particularly in those with chronic kidney disease, have set a lower eGFR limit. And you'll see here the limit ranging from 30 mils per minute in Credence through 25 mils per minute in DAPA to 20 mils per minute in EMPA-Kidney. So the investigators designing these trials believed that there was a limit, a lower limit below which we could not go, and possibly a lower limit below which we could not fix progression of chronic kidney disease because kidneys were so badly damaged. We have had patients with low eGFRs in some of the trials, and this is from the DAPA-CKD study showing 624 patients who had eGFRs, starting baseline eGFRs below 30 mils per minute, remembering that our lower recruitment threshold was 25 mils per minute. And of these patients, these patients formed 14.5% of the total population. And if we look at the outcomes in these patients, and you'll see here the primary outcome from the DAPA-CKD trial at the top and our 3 secondary outcomes, you'll see that the outcomes for these patients was really no different to the outcomes from the rest of the study population who had stages 2 to 3 CKD. Here are the tests for heterogeneity. So certainly in the DAPA-CKD trial, those patients recruited with these lower levels of eGFR were not showing any difference in terms of these primary outcomes compared to the patients with better preserved baseline levels of eGFR at the start of the study. So Dr. Hung and colleagues recognized this evidence gap. We have limited data in patients with eGFRs of less than 30 mils per minute and virtually no data among patients with eGFRs of less than 20 mils per minute when it comes to using SGLT2 inhibitors. And they conducted the trial that we've just heard about, the DAPA Advanced CKD trial, recruiting 180 patients with CKD stages 4 and 5, including, importantly, 56 patients who had stage 5 chronic kidney disease. As we've heard, there was no baseline albuminuria requirement, but they did select patients whose kidney function was declining rapidly, greater than 25 mils per minute. There were some exclusions that were similar to the exclusions in the DAPA-CKD trial. Patients on immunosuppression were not recruited, and they also excluded patients with a history of serious urosepsis. The randomization, as we've heard, was to dapagliflozin or placebo, as in the DAPA-CKD trial, but they used a lower dose of dapagliflozin at the start of the study, as you heard, and up-titrated to 10 milligrams once a day. And their primary outcome was total eGFR slope, the eGFR slope from the point of randomization to the end of the observation period. Now, there were some baseline imbalances which might have advantaged those patients randomized to dapagliflozin. You may have noticed that the average age was about 4 years younger, and around about 5% more of those patients were prescribed RAS inhibitors at the start of the study compared to the placebo group. They followed these patients up for a median of 84 weeks, and despite a 1 mil per minute acute drop in eGFR at the start of the study, they were able to demonstrate a 1.21 mil per minute corrected for body surface area per year slower rate of decline of kidney function in those participants randomized to dapagliflozin compared to placebo. And as you can see, the trial also met secondary endpoints, including a renal composite and some cardiorenal composite endpoints. So a positive trial, and importantly, although you could not see the error bars, consistent benefits across subgroups of patients, and in particular, and most importantly, a consistent effect when comparing patients with stage 4 to patients with stage 5 chronic kidney disease. The safety profile of the drug was good, even in patients with these lower levels of EGFR. You saw no excess of AKI events, which you might be worried about, and in fact, you saw fewer hospitalizations with acute kidney injury in patients randomized to dapagliflozin compared to placebo. There was no increase in hospitalizations due to urosepsis, remembering that patients with severe urosepsis had been excluded. There was no excess of volume depletion events, no mention of ketoacidosis. But there was a dip in EGFR of greater than 30%, which is, I think, where we begin to worry in 2 out of the 120 patients. And you might just want to bear that in mind if you're treating these patients and wondering whether you need to do a 4-week follow-up EGFR measurement. Now, these safety data are consistent with some safety data we've shown before. This is from the DAPA-CKD study. We presented this at the ERA not this year, but last year, 2023. And what we're looking at here is patients in the DAPA-CKD study who started dialysis during the trial. They started dialysis on study medication, or they started dialysis and study medication was discontinued. And we're comparing here participants in the trial who discontinued their study medication when they started dialysis or continued their study medication when they started dialysis. And of course, that study medication was either dapagliflozin or placebo. And we're looking at safety events here with any adverse events at the top, serious adverse events in the middle, and serious adverse events, including death, at the bottom. And the point this is making, if you look at the heterogeneity interaction, is that there was no difference, no enhanced safety signal in patients in the trial who continued dapagliflozin. So we were not disadvantaging patients or increasing adverse events by continuing dapagliflozin on dialysis in this patient population. Now, why would you give dapagliflozin to a dialysis patient? That's perhaps another question. But of course, there may be some cardiovascular benefits that extend into the dialysis period. So to conclude, the well-recognized kidney protective events that we see with dapagliflozin do seem to extend to patients with stages 4 and 5 chronic kidney disease, and I think the DAPA Advanced CKD study has helped to substantiate that statement. With the available data, we see no heterogeneity in benefit, even in those patients with stage 5 chronic kidney disease, and we have seen no unexpected safety concerns in this patient population with low EGFR levels. And I think what these data suggest to us is that we can start dapagliflozin in patients with advanced chronic kidney disease, EGFRs of less than 20. And in doing so, we may well prevent or we may well preserve renal function and delay the point in time that these patients need to start on renal replacement therapy. There's one study ongoing, which is just worth mentioning. This is the Life Cycle trial, which was started by Hiddo Lambers-Heerspink and his team in the Netherlands. This trial is recruiting patients with advanced chronic kidney disease, EGFRs of less than 25, patients on dialysis and patients living with a kidney transplant, and is randomizing these patients to dapagliflozin or to placebo, and is following up for kidney endpoints, all-cause mortality and heart failure hospitalizations. And I think we're looking forward to seeing the results of this trial in a couple of years' time. I'd like to thank you for listening to me. Again, thank you for the invitation to do the commentary, and thank you very much to everybody.
Thank you, Dr. Wieler, for the comprehensive overview, not only of the exciting study from Dr. Hung, but also the field. This concludes our early afternoon session. Thanks for you for staying. What I would like to remind you is this was the third of the 4 late breaking sessions we have at ASN. There's a session this afternoon from 4:30 to 6 p.m. in room 6C, as you see projected. Exciting data on xenotransplantation trials, IgA, Alport, APOL1, and ADPKD are presented, including several of these studies being released simultaneously at high-impact journals. So please attend the session and otherwise enjoy our meeting here in San Diego. Thanks, everybody.